group discussion. So Louise, could I ask you to go first?
Thank you, Wayne, very much. Can you hear me and see me?
Yes, indeed.
Excellent. So I'd like to say good afternoon, and I'd like to start by thanking the 2020 CADTH Symposium for inviting our panel to speak today. And I'd like to thank all of you who have decided to join us for this panel presentation. I'm sincerely honored to join this panel of dedicated colleagues in the monumental and often thankless task of developing and providing healthcare resources to oncology patients during this unprecedented time in our history. I'm going to take a few minutes to talk about one key collaboration that a number of oncology patient groups have undertaken since the outset of the COVID-19 pandemic to support cancer patients. And I'm going to start by describing the impetus for this initiative, and then I'm going to move to describing the implementation stage, and finally provide a brief analysis of its impact. And then I'd like to close by looking ahead to 2021 and what it might hold. Patient groups in oncology heard the clarion call to action early in this pandemic. It started with panic calls to oncology patient organizations in late March from oncology patients across the country who overnight discovered that their medical appointments, treatments, surgeries, diagnostics, and screening tests had been canceled or indefinitely postponed. They wanted to know about COVID-19 and its impact on cancer patients. They asked what would happen now that they couldn't get their tests and treatments. What would these delays mean to their chances for survival and quality of life? For those lucky few for whom appointments were still available, they wanted to know if they should keep them, fearing infection on their commute or in the clinic. One woman in British Columbia said that she was still being offered her appointment for treatment at a Toronto hospital, but was told that she would be refused if she came to Ontario on an airplane. She was terrified and desperate. Why was the healthcare system failing her? Didn't they understand that she would die without her treatments? Another was afraid to go to the hospital because she thought that people with cancer were more likely to get COVID than other people. She asked whether this was true and how could she keep safe as a cancer patient. A third wrote that she thought she might as well commit suicide because she couldn't travel to her appointments. She feared public transportation and couldn't afford to get to her appointments any other way. Patient groups shared this information amongst ourselves. We concluded that there were three key areas in which we could provide practical support to patients, and that the most effective way to do so was collectively. Save Your Skin Foundation, a national melanoma oncology patient group, under the umbrella of which I'm pleased to provide health policy advice to patient groups, was one of these groups. The 13 groups that banded together, now 15, decided to create a patient-friendly website that would provide a central repository for comprehensive resources in the following three areas. First, national and provincial government and community COVID-19 related programs and support. Second, mental health and wellness resources and services, as well as an 8-week virtual mindfulness program. And third, coordination and funding of round-trip transportation by taxi to medical appointments in pharmacies in Toronto and later Montreal. We sought funding under the auspices of Allcan Canada, a network of oncology healthcare stakeholders with a mandate to identify waste and inefficiencies in the healthcare system. 5 companies stepped up, including Amgen, Pfizer, Novartis, AbbVie, and Bristol Myers Squibb. On behalf of the patients who have benefited from these services, we thank them for their support. And thus, the COVID-19 Cancer Patient Support Hub, affectionately known as the Hub, was born, and it is totally bilingual. To develop and manage it, we created 3 working groups under the leadership of a team comprised of representatives from Save Your Skin Foundation, Lung Cancer Canada, and the Canadian Psoriasis Network, with amazing support from the project manager, communications manager, and a part-time taxi services coordinator who oversees an exceptional group of volunteers. The Hub has achieved its goals with close to 9,000 users and counting, both English and French speakers. At first, most were looking for general information and resources, but relatively quickly, we saw many turning to the mental health area. More than 160 people from across Canada registered for the mindfulness program. We have already provided nearly 500 round-trip taxi rides for people. As of yesterday, the demand for taxi services had reached approximately 6 round trips per day, or 120 per month. And this is only in these 2 cities. Anecdotally, one of the social workers at a Toronto hospital told us that people in the Greater Toronto area outside our catchment area are starting GoFundMe campaigns to pay for their taxi rides into Toronto for medical care. Who knew that our little idea to fill some practical gaps for oncology patients would prove to be indispensable? And who would have guessed that instead of decreasing, these needs would be escalating? This is in addition to all of the incredible hard work and resources that individual oncology patient groups have been providing in so many ways. In a time when our resources were in fact dwindling and the demands for services were growing exponentially, I'm proud to report that patient groups more than met the challenge. It definitely begs the question for me about where these patients would have gone without our collective and individual initiatives to fill voids left by inadequate pandemic planning in an already overburdened healthcare system. Which brings me to 2021. It is clear that this pandemic will extend well into next year. Virtual care is on everyone's lips. Governments are funding this approach to healthcare delivery, betting on it to fill the gaps. Many regard it as a panacea for our healthcare delivery problems, and in my view, antiquated healthcare system. It is no doubt an important tool for patient care and will play a growing role. It is not, however, the answer for every patient or all the time. In-person healthcare provider visits will continue to be an essential component in cancer care, and so will the services of the Hub. In closing, let us all ensure that virtual care is delivered in the most effective, efficient, and user-friendly manner. Let's also ensure that those people in Canada who have limited access to the social determinants of health will also have access to this healthcare delivery tool and to all the other services needed for their health. Thank you.
And deal with those. And perhaps if you don't mind, I might start off, I guess, with something I think, well, all of you have touched on, but Louise in particular mentioned about how we're learning some things that will carry through to improve the system going forward. I was just wondering if you're able to elaborate on that. What are, Louise talked about virtual care. We've all talked about virtual care, right? But what are some other things that we might be seeing in the way that patients are going to be treated, oncology patients are going to experience going forward, lessons that we've learned from the epidemic? Louise, can I ask you to start?
Sure, thanks, Wayne. First, I want to remind people not to put on their 2019 rose-colored glasses about the healthcare system. It wasn't really working for cancer patients before this pandemic. So, let's not start to get nostalgia about our great old healthcare system. It had a lot of cracks in it. Those cracks have become chasms, but those chasms wouldn't have existed if the cracks weren't there in the first place. So I just want to remind everybody about that. So I don't think we want to build back better in the sense of going back to what we had before and just putting a bit of ornamentation around it. What we've really learned, I think, from this pandemic is that we need to profoundly change the way we deliver healthcare in this country. And that is to say, for example, everything doesn't have to be done in a hospital. We don't have to have blood work, every test, pharmacies, all of these other services necessarily under one roof. And in fact, I think we would have been better served moving into this pandemic if we had not had that kind of way of managing so many of these services. So I think that's one thing certainly that many of us are starting to think a lot about. We were thinking about it before and we're really thinking about it now. In fact, I think we've also learned that healthcare delivered at home, wherever possible, would be optimal for many, many patients. And that we could do that in a much better way, which of course leads to one of my main complaints, which is the siloed budgets that we have in our healthcare system. And until we unsilo and bundle services around the populations who need them, we're really just going to keep building the same old car we had before this pandemic, instead of really moving to something that I would call revolutionary, but it's a quiet and good revolution for sure.
Thanks. Kevin, John, either of you like to add anything to this?
Well, I'll go first. I want to, again, agree with Louise. I think everything that she said is exactly what I think. And, I alluded to it in my statement where, our system was far from perfect to begin with. And I think COVID just exposed that even more. And then there are a lot of things, particularly I deal with more of the systemic treatments and obviously the active cancer care. But there are a lot of things that, we don't mention a lot, which is the supportive care aspects, getting home care for those who need it. A lot of my patients are isolated and they don't have the support. And now we're asking them to come in, taking public transportation, finding taxis when they don't have the means to get it, to do tests, blood tests, scans, and so on and so forth. And you add the added obstacle of COVID and all the problems that entails for a patient population, which is considered all fragile and at risk. And there are many ways that I think that COVID has shown how the system is failing these patients by asking them to do more with less, which I think is challenging even in the best of times. So I think we should see COVID as an opportunity to sort of, like Louise said, revolutionize the way we deliver cancer care. I think the way it was done before was adequate, perhaps maybe 10 years ago, maybe 20 years ago, but cancer care is changing every day. The way we ask for tests are different now. The way we deliver treatments is different. We have different therapies. So I think we can adapt, and I think COVID should be a springboard to allow us to sort of stimulate those changes. But my fear right now is that I think governments and agencies are just scrambling just to figure out how to deal with the actual problem. And I'm wondering if the thought process in how to revolutionize cancer care is even in their is even in their view screen. My hope is that if we cry and shout loud enough, we can make them aware that there are definitely problems that were there before COVID, they're now worse after COVID, and hopefully we can find ways of solving them.
In your experience, Kevin, how have patients responded to use of telemedicine your cancer patients? Is there much use of it, and how do they respond to it?
So I have two groups of patients, and again, I want to remind the audience that I treat lung cancer, which, I have very young and very adept patients who know how to use technology, and I have those who don't even have a cell phone. So you can imagine those who don't have a cell phone, who don't know how to use, the internet, that it's not necessarily easy managing very sick patients. One thing that we've been noticing over time is that patients would report their symptoms. They would say, oh, everything's fine, because they were scared of not getting their treatment because they felt that perhaps the physician would stop their treatment because they're too sick, when in fact it's the opposite. We want to help them and want to be able to give them the most appropriate care. But then when we would see them in the hallway, we would realize they're in a wheelchair. But that's not something you can gather from hearing on the phone. I actually had a couple patients who had abscesses on their chest wall, but they actually thought it was a pimple until I examined it and realized it was actually something even more grave than that. So it's I came to realize that telemedicine is a very useful tool for certain patients. One of the advantages I think I see, and I think some of my patients appreciate, is that some of the things that we don't calculate in our budget is, patients who have to come down and pay for parking, patients have to take time out of their day to come see a physician for what would be a quick, follow-up appointment for some of these patients when they're doing well. Well, I think telemedicine allowed us to ease that kind of burden from their daily lives, and they're able to sort of, take advantage of that. And actually, they are the patients who appreciate it the most. They're also the patients who are deathly scared of getting COVID. They're hearing things on the news about, oh, COVID is all over the hospital, so I don't want to come to the hospital. Well, telemedicine allowed us to at least keep touch with these patients. But like I said, I think it's not a perfect system. There's access to technology is not always easy and evident for everybody. So it does have its limitation. And I think you can't see it, as Louise had mentioned, it's not a panacea for curing the problems of our healthcare system. It's far from that. It's a bandage solution, one which I hope can be resolved in the next few years. But certainly it's not something that I would advocate replacing the way we do medicine today.
No, thank you. That's very helpful. It's also a reminder that every patient is different, right? Everyone's unique, and that's a key part of treating patients. John, I really was interested in your example of your colleague looking at ways of transferring some of your knowledge and experience from your immuno-oncology to working on a COVID vaccine. Can you tell us a little bit more about that?
Yeah, I think, the whole cancer world is really excited about cancer immunotherapy because it's starting to change the paradigm of how you treat patients and hopefully use the patient's immune system to recognize that cancer is foreign. That's a challenge. We're making a lot of progress in that area, but that's actually quite difficult to do because your cancer is a lot like your body. It's a part of your own body. So trying to convince your immune system to recognize that as foreign is a challenge. And we've been using lots of strategies to do that. In the case of COVID, though, this is a foreign entity. The virus is completely foreign to us. And so what we can do is find ways to make our immune system recognize it better and faster and appropriately so that the patient has a good response. And so a lot of the things we were applying in cancer immunotherapy to a really challenging problem are a little easier to deal with in the case of COVID. And we're really rapidly using those technologies to make what I think are extremely potent vaccines, which we're hoping to get tested into people fairly soon. So I think it's really was a bit of serendipity to some extent that we were in that particular position at the time to be able to pivot our ideas. But at the same time, we've learned a lot from those experiments that we're going to take back to the cancer immunotherapy space. And so it's really been a bit of a cycle, which I think has worked well to our advantage. But, I just need to follow up briefly on what Louise and Kevin said is, and I totally think they're 1,000% right that we just keep doing this reactive thing as a country rather than being proactive and changing things. And the virus that causes COVID-19 is called SARS-CoV-2 because we've had SARS-CoV-1 before. That was the SARS virus, and we had that in Toronto. And at the time when it happened, there was outcry. Why don't we have more scientists working on this? Why, blah, blah, blah. Well, it's because there was no funding for it. And even though we experienced that and we were lucky to get out of that virtually unscathed, essentially as a country, except for unfortunately a few people who were, it's nothing like this pandemic. We didn't learn from that, and we didn't change our funding models. And had we done that, we would have been in a much better position to deal with this pandemic. And my concern is the same as Kevin and Louise's, is that we're not going to learn from this. We're going to have this reactive funding envelope to try to quickly get a vaccine in place instead of continuously good support for healthcare, good support for research all the time, so that we're in a much better position to respond. And it's been well established that countries that invest in science have much better economies. And so I really must say I'm continuously confused by our government's not understanding the value in investing in science and healthcare, because that's what Canadians want. And but anyhow, that's me. I'm easily fooled, I guess.
If I can add something to what John said, and actually he alluded to it in his presentation about shutting down clinical research. And I am clinical research director, and I believe a lot in clinical trials. And one thing that happened during the COVID was all clinical trials in Quebec was shut down. It wasn't even given an afterthought. It was considered to be a non-essential service. And the reasoning was, we want to focus on treating COVID, which is fine. The problem is that clinical trials, particularly on oncology, are sometimes a lifeline for these patients. They are, in my mind, treatments that could save some of these patients. And so what it brought about is that it showed me that the governments haven't considered clinical trials or research as being a priority for care of patients, cancer care or whatever. And now we're all excited about vaccines, which are about to come, which come about from research, obviously, which is a little ironic. But I would hope that we're going through a second wave, and hopefully not a third, but that there's a different view of research as not just being something that's experimental, but actually something that's therapeutic for our patients. And I really would want the governments to see it and look at it differently than they have been in the past.
Yeah, I think you
I have to make
a lot of support. Louise, please.
Make a comment about that as well. I entirely agree that everything you've said, but it's all very nice to champion science, but if we don't start actually creating systems to reimburse for drugs once they've been tried and proved to be safe and effective, there isn't that much incentive for that research to be done in this country. So you can't see one part of the system separate from another, unfortunately. And that's another thing that somehow seems to happen in our healthcare system is, research is not seen as part of a continuum to access. So it's a big problem. And John, I'm as confused as you are.
Yeah, I was thinking, Louise, you talked about the silo approach to budgeting, but also silo approach to policy making in government, right? And there doesn't seem to be a connection sometimes between, in this case, the importance and necessity of good scientific research on balance in terms of other priorities of government. That's something you can't put aside. You don't throw out a pandemic plan, for example, as was alleged in another country. I don't see any questions coming up. So my first question is to the folks, our session hosts and others. Just, am I looking in the wrong place, or are we just not getting any? So please feel free, those on the line. please feel free to jot down in the, I assume in the chat box is the right place to do this, any questions you might have, and we'll try and take advantage of this great panel to address them.
May I, in the meantime, may I talk about another set of profound silo issues, and that's about seeing us as from here to from our head up and then from our body down as being unrelated to each other, by which I mean you can't have good physical health if you don't have good mental health, and vice versa. And I think that's another lesson that some of us already knew, but I think the general public is now starting to understand that you cannot split us up and treat us separately. Mental health and physical health are inextricably linked, and we're so far behind in terms of mental health services for oncology patients and people generally. And speaking of that, I really want to say that I'm worried about burnout from our medical healthcare professionals, all of them. It's how can they keep going at this pace? That, of course, will affect all of us.
Yeah, that's a good point. So unfortunately, I've screwed up, I think, and I don't have access to the question screen. So my apologies to everybody for that. But could I ask, Jose, could I ask you to do me a big favor? Can you maybe just share some of those questions verbally with us?
Yeah, if you give me a minute, I'll try and log into the Q&A piece and get some questions for you, Wayne.
Okay, great. Yeah, okay. Yeah, sorry. My apologies for that. A good question actually that I do see here now is on the question of essential and non-essential services, and Kevin talked about that in terms of clinical trials. Obviously, cancer care would seem to be an essential service, and that's continued, but seriously hampered along the way. So, what how do we? Is there any way that we could try and perhaps change things so that we can deal a little more readily with some of these challenges in terms of ensuring ongoing proper cancer care?
I don't know if I have the right answer to that. That's way above my pay grade, unfortunately. I think the problem, and I think we've alluded to it at several steps, today is the system, the right system to deal with the COVID, pandemic? And the answer is clearly not, because I think the system was designed to go a certain way at a certain rhythm. At a certain pace, and I think most people would even argue, at least those in the healthcare field would probably say that it's an imperfect system to begin with. Like a lot of our nurses, Louise touched upon burnout, and I think a lot of our nurses were already on the verge of being burned out anyways before the COVID situation hit. They were then asked to do even more when the COVID situation hit. Just to give you a bit of context, in Quebec, as some of you may or may not have seen on the news, well, a lot of our long-term care facilities, especially in the public system, were being ravaged by COVID. A lot of the healthcare professionals, the patient attendants, the nurses, they were getting sick. We actually talked about 10,000 healthcare professionals that actually left the system because of COVID, and then we had to replace them from people from the hospital. So one of the direct impacts that we saw was that nurses from the OR who normally would have been operating on patients with cancer were asked to go to these long-term care facilities and actually work in very, very strenuous and very tough environments, and then come back after actually having no time off. And so we're very worried actually at the very moment that a lot of the healthcare professionals are not going to last very long. We've been hearing about nurses quitting the system because they just can't do it anymore. It's not something they find is sustainable on a personal level, and I can understand. You know, I'm not going to complain about the workload at all. I would say that the COVID situation definitely has brought about a lot of stress and anxiety on my part, not only because, you know, I'm exhausted working difficult hours, but also, you know, I did do some COVID wards. I actually was in our hospital treating COVID patients that didn't have cancer, for example. And then I had that added worry about bringing that back to my family. So, you know, all these things I think a lot of the healthcare professionals are thinking about. And so what that shines a light on is the critical understaffing that's in a lot of the places. You know, there are a lot of cancer centers. I work in an academic institution, but there are a lot of institutions that are not academic, that don't have the same staffing or the same resources. And that has direct impacts on patient care. And I know that the healthcare system tries and patches things, and that's usually what happens when there's a problem. You know, there's usually someone crying out a little louder than others, and then the government reacts. We talked about being more reactive than proactive. But I think if we could come up with a more concerted, fundamentally solid plan going forward, how to adapt our healthcare system with the changing times, the changing demographics, the changing way people live, I think will go a long way to solving the problem in the long term. The problem is that I think our healthcare system is pretty antiquated as it is, and I don't know if it's going to be easily changed, but that's why I think if we have enough people saying, why don't we look at the fundamental problems of our healthcare system, I think this will go a long way to fixing it down the road.
Thanks. Anyone else want to comment on that before we go to the next question?
I can make a few comments, I think, as well, although it should be above my pay grade too, because there are a lot of people being paid a lot more to figure this out than we are, and they're not doing a very good job so far. So at my low pay grade, I'm going to try it too. First of all, we have the federal provincial problem where healthcare funding is divided up. You know, and so the federal government gives a bit of money to the provinces for healthcare, and then they're left to their own devices. And unfortunately, all provinces are not created equal. So we end up with this patchwork quilt, as it's been called many times. That's got to somehow be dealt with. Everybody across this country should get at least the same minimum healthcare that everybody else is getting. And I guess I'll have to become a constitutional law expert to figure out how to do that, but it has to change. Another part of the problem is that we have a separate health budget that doesn't take into account social determinants of health. And so, you know, if you're not housed, you're gonna get sick. If you're poor and can't buy decent food to eat, you're going to get sick. There's so many other factors that impact health that are treated separately in separate ministries across this country. And so somehow all of that has got to be brought together, and we've got to stop seeing them as competing interests for competing dollars, but rather we should all be rewarded when people are healthier, whether you're in the housing ministry or another ministry. If people get better, the risk rewards and the punishment rewards should be shared out across the system. That's another problem. And of course, you know I'm going to say this. If you don't know me. Patients should be listen to and have meaningful decision-making opportunities across the system, and we don't. And I would say that our partners on this panel should also have equal decision-making power, and you don't. So those are at least three, and as I say, like you, Kevin, my pay grade's pretty low, so that's about as much as I can offer right now.
You touched on a lot, as always, Louise, some very good points, but I don't think we're going to solve the federal provincial issue today. But But let's face it, that is key to all this. Who's responsible for what, and who pays for what, and so that's an ongoing challenge. We've had a lot of great questions coming in now, so I'm just going to jump right to them. And one, I'm going to get right back to you, Louise, on this one, because it's addressed to you. And
Okay.
the question is how might CADTH help to overcome the many disconnections, bottlenecks, and other obstacles that the presenters have outlined? What's the role for CADTH in all this?
I think that's a terrific question. Thank you, whoever sent it in. CADTH is in an amazing kind of place because it talks to the federal, it's aligned with the federal government, and it's aligned with the provinces. And so it has an opportunity, I would hope, to bring them all together. And it's not a funding body, so it doesn't have to be afraid about calling the meeting, in the sense that no one is going to expect CADTH to be writing a check, which is what I often hear both from federal government people and the provinces about calling any meetings. Well, they'll think I'm calling it because I'm willing to, sign a check. CADTH is not expected to sign checks, but it is working on alignment, and I'm so pleased about that. And that maybe is the entry point for CADTH. It's working to align with the health technology assessment body in Quebec and with Health Canada. And of course, it works very closely with the Pan-Canadian Pharmaceutical Alliance. So it is actually in an ideal place, and it works with patient groups and permits us an opportunity to provide meaningful input into its decision-making processes, as well as the doctors through submissions. So it's actually in an ideal position to call the meeting, as I like to say, and to bring people together to have the conversations that have to be had. And they can do so in a way that's everybody takes their hats off at the door. And let's have just some honest conversation about the problems that we have.
Super, thanks, Louise. And I'm sure CADTH folks on the line were listening and paying attention to that. And that's a very helpful and good advice for sure. A couple of questions here on another topic altogether, and I'll go to John and Kevin on this. And I guess it's a question about how to deal with the backlogs. I guess it is the how to deal with the potential delays in diagnosis, maybe people not even going to their doctor to check something out. What kind of a backlog are we going to have, and what are the longer term implications of that? And are there things that we could be doing differently now to try and start addressing those concerns?
I can start on that because I guess it's more of a clinical question. The one thing that I noticed that it was always easier to shut down things than to reopen. And so one of the things that we saw was that it was very, very easy to shut down getting access to scans that were both diagnostic. The mammogram program for breast cancer was completely shut down for many months. I don't treat breast cancer, but I was definitely aware of the situation that a lot of our patients who were waiting for screenings, and they're not easy to get, even though it's a publicly funded a program, just because of the volume. So you can imagine what 3, 4, 5 months of stopping of testing that could do to a system. And how many patients are going to come out with a more advanced breast cancer just because they didn't get their early detection. And we are seeing not only that, we had our colonoscopy suites that were shut down for the 3 months of the first wave. Bronchoscopy suites for lung cancer were also massively shut down because of the aerosols that could generate. So what that really shed a light on to me was that the funding that was provided for screening, for example, was quite inadequate. And we were, I think it was quite clear before the COVID situation that it wasn't easy to get your colonoscopy. It wasn't always easy to get access to specialists. And I think one way that I think we can get things back on track is finding other avenues, like Louise had mentioned. Does everything have to be done in a hospital? Can we find other ways diagnostic places that can be done outside the hospital that can be publicly funded. I think there are different ways of finding solutions, but if we're just going to continue to rely on the public system, which is already woefully, in my mind, funded in terms of being able to, get all patients tested for, whether scans, colonoscopy, endoscopies, I think you're not going to solve the screening problem and the backlog very fast. I think you have to be more creative. I think you have to be way more outside the box. I'm not saying that we should go private, or that's not what I'm saying at all, but I think you can find partnerships that would allow us to be able to reuse resources that are outside the hospital and be able to get the waiting lists down quickly. That's the only solution I can see today outside of something that's more revolutionary.
Yeah, we haven't talked too much about potential partnerships to address some of these things, Kevin. I'm glad you raised that now. But, John, can I switch to you though for just to follow up on some of the points you made about the funding of research, and in particular the fact, of course, that charitable organizations saw a real dip in money that they have available to fund research. Obviously, CIHR, all their attention diverted to the COVID issue, and what I thought was important in what you said was that it meant the halt of some research, and I think Kevin and Louise also talked about the halting of clinical trials. Have you thought about how we might, if we found ourselves in a situation like this again, how we might look to perhaps more stable, both funding, but also, I suppose, management, if you will, of clinical research in the future?
Yeah, that's a great question. And I think what you've been hearing from Kevin and Louise is that we need to have a step change in our thinking here. We can't continue on as we've been doing. It's just not working. And as soon as the system gets stressed by something like this, it virtually collapses. So I think we really need to rethink how we fund research, how we fund healthcare, and Louise is bang on about other aspects of society or helping people in society, because that clearly impacts all that we do. And there are other examples out there. I would, there's other countries that use variations of our healthcare system to do much better. For instance, Germany's one as an example. And I just think that it's, this has got to be a wake-up call for everybody. Let's get ourselves to think about this in a better way. This cannot go on. And there's no need for people to be dying or be suffering the way they are just because of a lack of organization, basically, and funding. That makes no sense to me. So I think if we don't rethink things in a global way for our country, and maybe some privatization is appropriate, and maybe that's just what we have to think about. Tommy Douglas is going to roll over in this grave, but so what? Maybe now's the time to say we do need multiple tiers. And it doesn't mean that it's two tiers of care, but maybe people who can afford to pay more should find a way to pay more. And I just think that it's time now to think about this, and not, I have the greatest admiration for Terry Fox Foundation and Canadian Cancer Society and all the other ones that are out there. They're phenomenal groups, but they go out and have to beg for money to fund the research that we all just need. And that is also, it shouldn't be the case. We should have ways to get research funded so we avoid these problems. It's, like I said, there's SARS-CoV-1, there's could be COVID-2 now, there could be COVID-3 or something else. Let's rethink this now and prepare ourselves so we can respond better. And also, let's behave ourselves as a society. I can't believe how people still go out and party and so on, when we know the answer here is just don't do that for a little while until we can catch up. And yet we're putting people like Kevin at risk all the time by going out and having to have our parties in the backyard. And I just think that as a country, we're better than that, and we should do better than what we've been doing.
Yeah, no, that's, thank you, John. That's very, very important thoughts there. I noticed the time, and we have a hard stop at 2 o'clock. We're going to be turned into pumpkins then. So I want to just see if we can just take a couple minutes for any final thoughts from Louise, Kevin.
Well, thank you, first of all, Wayne, for, oops, I think I'm muted.
No, you're good.
Oh, you're good.
Now I'm good? Oh,
Yeah.
good. It wasn't showing. First of all, thank you, Wayne, for facilitating this conversation. It's hurting cats, I know, but you've become very good at that. And I guess, I don't really have any more to say except that I'm so glad that still as a country, unlike some others that I could name, we do believe in a social safety net, and we do believe that we have responsibility to some degree for each other and not just for ourselves. And you're right, John, there are with exceptions, but we must never lose that, because I think that's at the heart of the best of us as Canadians. And I also want to say that I've worked with a number of new Canadians, if you want to call them that, people who've immigrated to this country, and they bring a richness that we really need to also learn to understand and to build into the fabric of our thinking, because they have a lot to teach us as well from the terrible experiences that many of them have had in the countries from which they've immigrated. So I still have hope for us, but we need to continue to work together if we're going to solve any of these problems.
Great. Kevin?
As an oncologist, obviously, the one thing that I know, whether there's COVID or not, cancer doesn't stop. It's never going to stop. It's always going to be there. And so whether or not there's going to be another pandemic, whether or not there's going to be another event that will throw a wrench into our health system, you can't lose sight of the fact that we need to continue to provide cancer care at its best for patients who really need them. We're talking about really patients who are vulnerable, who have enough to deal with. They have enough stress to thinking about how are they going to provide for their family? What's the next 2 or 3 months of their lives going to be like? And if anything has been shown is that, a lot of the isolation that's been due to COVID is even more exemplified. So I think there are a lot of things that I think we can learn from the COVID situation in terms of how it impacted us. And my hope really is that the lessons or the things that we learned from COVID will be applied and to be able to better the way we can deliver cancer care to our patients, whether there's a pandemic or not.
Super. Yeah, thanks. Yeah. John, I kind of took it that you kind of already gave some closing remarks, but you're good? Okay. Well, I think we're going to close it off there. And I want to really thank Louise and the folks who brought this topic to CADTH's attention, to CADTH for accepting it and holding this panel. I want to thank all of you individually for the work that you do. And I know you've all been working extra hard and under more challenging conditions than ever over the past 9-10 months. And I just want to thank you all for that, and to your colleagues as well and families. I know that at the end of this session, I feel a lot smarter than I did going into it. So to me, that's a sign that this was a good session. I really want to thank everybody once again.
Thank you.